welcome to the second part of our recording series. In this recording, we're going to talk about how do we refer residents to appropriate allied and mental health services, what services are available, what commission services, what about the referral and review pathways, the care coordination, the components of that are essential. How do we get that collaboration and communication? So Riwka Hagen from Medical Business Services and Kim Poyner from MediCoach are presenting this for you today. And firstly, we'd like to acknowledge the traditional custodians on the virtual lands on which we all meet, past, present and emerging. So Riv, without further ado, how do we start even to refer people for these services?
Yeah, well, look, I guess, Kim, it starts off with, well, which arm of the new Medicare services are we referring to, or which parts of the commissioned services are we referring to? So I think before we can refer, we need to be just really clear about the, the programs that we are now engaging with, because that will kind of determine what those referral pathways will be. So remember, we've got the PHN commissioned services, which, will be commissioned directly through the PHN, and, the methodology around whether it's a phone call or whether it's an online form, that's going to be quite bespoke to each practice or each region. And I guess we really encourage practices to tap into their health pathways and have a look at, firstly, what commission services are available in your region and in your territory, and just become familiar with the referral pathways there. Whether it is Medicare benefit schedule type of services, whether it's for allied health or mental health, it'll be just the usual referral processes that you are already well acquainted with through just general practice items. So if it's if it's through a care planning component, which in this case would be either a 731, the existing contribution to an RACF developed care plan, or whether it's one of the newer item numbers that we've absolutely delved into quite deeply in the previous session, the normal referral pathways will stem from that as well. So it'll be a written referral that comes along with that whole care planning component, and then, of course, referring to the relevant allied health and mental health professionals who are actually providing services to the RACFs. So in terms of, is it a one-way, one process fits all? No, it really depends on the program, and really, sort of tapping into that. And of course, some of the other programs you can kind of directly apply to. So this is sort of the Head to Help and the Beyond Blue type of programs. They're available for anybody to tap into, and certainly the web-based approach would probably be the easiest way to go there. But I think more important than what's the documentation requirements there is, how do we actually facilitate that and get that process of care going? And the piece of paper is really only one component of that, isn't it, Kim?
Absolutely, Riff. And I think, what's essential is that a care plan's put in place. And if you see that those 5 initial allied services are used, and you think, wow, this patient could access the physical therapy allied services, those 5 additional ones, you can do an EPC form and a review, right? Not only that, what's essential to it is, which what Riwka just highlighted then, is who's keeping an eye on all this. So really, there's going to be a strong need for care coordination. What is care coordination? It's about having that person and that family at the centre of care, and then knowing who is out there that you can access and refer into and collaborate with and communicate with, because we want that interdisciplinary communication happening, so that we can provide specialty services that really bolster and support the needs of that human in that moment. So what I really would advocate is that there's people that are nominated to these roles. A care coordinator at the RACF end, hopefully that's achievable depending on the RACF and the way that they workflow. And the same with a with a GP practice, is having someone that's across these services, so they know how many EPCs or referrals have already been utilised. So how can we administratively make it less burdensome for the RACF to do that work, but also have it so clearly available and accessible for the GP team to see how many vets have been used, and is there a need for additional services. So there can be things like case conferencing. I think that's a really great way to really bring the team together to have conversations with the family. What does this person need? What's available in our area? Looking at, as you said, that health pathways, what services can we provide, and how are we going to keep track of it, right? So communication is going to be absolutely vital. Team-based care here. And it's not going to be just internal teams, independent teams working separately. It really has to be that interdisciplinary approach where everyone's here and wrapped around that person. We're all communicating so that everyone knows what everyone else is doing.
Yeah, and it's quite a complex space, isn't it? Because we already know that just internally within general practices, getting those systems, fine-tuned and humming along nicely, that's a challenge. And we know that there is still a fair bit of work to be done in that space because, from some perspectives, there is technology that will help us to do that. But when all is said and done, it needs people to interact with those technological tools to kind of make it a little bit easier, and that intentionality around driving those programs. So I guess what sits behind that to a large extent too is your internal resourcing. Someone needs to wear the hat, needs to carry the responsibility for making this happen. So who's responsible within your practice for looking after these programs? And I guess I would say whoever kind of wears that chronic disease management hat, whether it is a formal title of a care coordinator or a lead nurse or the title really doesn't matter. It's who's actually doing that work and then sort of refocusing that within that next level of complexity around RACFs. And I suppose we really want to reiterate that the difficulty of doing the work is so rewarded with the fact that the services are so desperately needed within the aged care facilities. And that's why we're really asking practices to step outside of their comfort zone, because really by looking at those external systems, guess what? It's going to make things easier internally too, isn't it? I mean, if you can crack that nut and get the aged care services ticking along a little bit better, that's got to have payoff within the practice team and internally delivered services as well. What are your thoughts around that, Kim?
Yeah, I just think if we can reduce after hours demand, right? Even with frailty, falls, all of those other risks that are associated with deconditioning, that's going to be a big trade-off, isn't it? If you were putting in that proactive management to prevent that after hours demand would be a great outcome in itself. And again, reduction in going into hospital and in the discharge plans and all the work that goes in behind that as well. I think that the real trade-off is, the collaboration that can happen between residential aged care facilities, and again, having some person that's actually allocated to that role means that hopefully we can reduce those phone calls and the demands and the fragmentation across both teams.
Yeah, I wonder too, just a bit of a side thought is, we know that staff in RACFs, there is high turnover, just like there is in practice teams as well. But by building those relationships a little bit stronger, I wonder whether we actually end up supporting each other so much better as well, which may well sort of tap into that notion of job satisfaction and feeling like you really are part of a bigger team and a bigger purpose as well. I'm sure that RACFs are well, they hopefully are very welcoming of that further collaboration with the primary care teams as well. well, and someone's going to take that first step to open that door and say, we need to get together and we need to communicate around this, because there is such complexity. It's not a simple checklist and off we go and all is dandy. There are some very significant relationships that need to be built up to get understanding around some of the complexity in these systems. What do you think?
Absolutely. And I think the residential aged care facility staff are the ones at the point of care. And they're the ones that are going to pick up the nuances of, has there been deconditioning? Has there been loneliness? Is there more depression symptoms and signs coming up in their clients and their residents? And does that referral need to go through to the GP team so that a mental health care plan can be done? The referral pathways that we outlined in the very first recording can start to happen so that we can provide 20 services. And is that virtual services because of your area and your workforce? But that needs someone really driving those initiatives. And I think the best person to do that is a person that's interacting with that resident on a daily basis. And the other thing that I think would be fantastic if we can see more Aboriginal health workers and Aboriginal workforce assisting doing those Aboriginal health assessments, Riff, as well, knowing what's available in your area and regions that you can really bolster your workforce with and support services to those clients. As Riff said, it's a complex system, no doubt.
Yeah, and certainly the PHNs are going to be instrumental in connecting the Aboriginal health services perhaps with primary care, who may not be quite as involved with Indigenous health as well. But look, I agree, now that we've got new item numbers specifically for Aboriginal Torres Strait Islander residents, that would be awesome to really bolster the Indigenous workforce around that as well, to get those better outcomes. So it's a whole lot of work that needs to be done, but I guess we do get just so very passionate about the opportunities that are there, but that need to really be tapped into.
Absolutely. And I think, it highlights again, when we think that things can't happen, what about when we turn the lens onto, well, what might be possible here? If I can't do it by myself, and this is the true care coordination hat, who else do I need on my team to make this happen? Yeah. And having that strong sense of why we're doing this, going back to the Royal Commission recommendations of why we're trying to achieve what we're trying to achieve. Yeah.
Yeah, absolutely. And I guess that also puts the lens onto perhaps the ability of practices to come together to jointly remediate some of these service issues for residential aged care facilities. And look beyond the immediate practice team, but also at your other GP practice cohorts, to see how some of these good outcomes can be achieved together. And yeah, it's an exciting space, isn't it?
Well, there's nothing like the breeds success more than looking for vicarious experiences, and particularly in the last recording, you'll hear the gerontologist, Jessie, speak about a really beautiful model of care where care coordination can be really, truly honed and refined at its best. So looking for those models of care, and you think, well, maybe I can't achieve all that, but which bits could you achieve is what I'm saying. Let's look for the opportunities, yeah, rather than just the barriers always. So looking for those opportunities to proactively manage clients as well. So residents, what we know particularly produces those better health outcomes is proactive management. And we know that that's 3 monthly reviews. Now, if that is not achievable, what can you achieve? Looking at how often can we proactively manage those? And that is where the care coordination role really comes to shine.
So thank you, Kim. There's been a wealth of tips and hints in the first two webinars that have been recorded. We hope that you found that really useful to help you get started with your further journey along RACF healthcare services and the new mental health and allied health service opportunities. We'd encourage you to stay tuned for the next webinar, which is a further panel discussion with GP Eva Pieko and Dr. Jessie Zanker. I'm falling over the names at this point in time, but that was that's a terrific conversation too, with some stories from the coalface of how these services really can be implemented, and some absolute passion from clinicians actually working within this space. So stay tuned, come and join us for that, and thanks for undertaking this webinar.